Om Amriteshwari Nama, and a very good evening to everyone present online and offline. I'm Dr. Ramya Shanai, alumna of 2008 batch and host for the day. Let's move on the proceedings by invoking Amma's blessings. A simple, unassuming person who handles every situation with an unparalleled calm. Due to an unavoidable meeting, Dr. Prem Nair sir could not join us today. So, I would like to welcome him in his absentia. An emergency physician, a singer, an author, and currently the principal of AMRITA School of Medicine. He has many feathers on his cap. I would like to invite Dr. Girish Kumar KP to address the gathering and officially inaugurate the event. I welcome you, sir.
Om Amriteshwari Namaha. A warm welcome to all those who are participating in this Global Amrita Alumni Network meet. We know that many of our students, they are alumni, they are working in various fields of medicine. They all did their MBBS or specialty or super specialty from our institute. They are now giving back to us, giving back knowledge to us. So here we have a student, our own student. He did MBBS in our college. Dr. Vijhay Ganesun, he is our student in MBBS, and MCH surgical gastroenterology he have done in our own campus. Now he is a consultant in gastroenterology and transplant surgeon. Now today, as part of our global alumni network meet, he is presenting a very important topic, that is liver and obesity. We know that there is a close relationship between obesity and liver. We all learned about fatty liver, cirrhosis, how fatty liver is progressing to cirrhosis, what is the need of liver transplant, or what are the treatment options. We all learn in our MBBS curriculum. I am addressing our students who are participating in this meet. We know that many of these patients can ultimately develop chronic liver disease, cirrhosis, or many of them may ultimately end up in liver transplant. And we have our center is one of the best centers in country that we do large number of liver transplantation in our center. We have great surgeons, a great department of gastroenterology and gastrosurgery. So today, Dr. Vijhay Ganesun is going to talk about a new type of, like it is not a new type, it's actually the detection rate is very, very high nowadays, liver and obesity. I welcome Dr. Vijhay Ganesun and all audience, like including our students, panelists. We know that great panelists are joining. Our students, I hope that this type of alumni meet, actually this is a type of career guidance also. Many of our students, when they are joining for MBBS, they don't know what to take after MBBS, what to take after MS or MD. So some of our students are having a leading role in their career now. So they can actually advise our students. I requested PG Madam that many of our students want guidance, because nowadays we know that even when we were students, nobody used to guide us. But now we know that many of our faculty or alumni, they can guide our students in this field of medicine, because nowadays we know that the branches in medicine are large, the number of branches are very large. So our students, our senior students or our alumni can actually guide them also. So I requested PG Madam to have a career guidance type of program so that our students will get benefit from this type of speech. They also get it's a learning class. They can learn about liver, fatty liver, obesity induced liver disease, but they also learn about new career opportunities in liver specialty, how to become a gastroenterologist, how to become a transplant surgeon. All these things we can discuss here. So I welcome Dr. Vijhay Ganesh. He is a alumni. He is a rank holder in our college. I welcome him for this prestigious meet, AMRITA Global Alumni Network meeting. It's a series of discussions, events that is going to come. Om Amriteshwari Namaha. Thank you for.
Thank you very much, Dr. Girish sir, for coming here, leaving many schedules of yours in your office. A series of talks, as you said, we are organizing from the alumni side. And the first topic is going to be today's topic, that is liver and obesity. The next topic will be by Dr. Jyoti Priya, and that is going to be kidney and diabetes. It's going to be an excellent opportunity for all the alumni as well as our students to follow these classes. I would like to inform all the alumni that there is a link provided in the earlier magazine. I will also show that link at the end of this session. Please register in the link with all details to get the unique digital ID card. Universities from globally are a part of it and is very valuable and useful to all of you. If you want to enter into any of the campus abroad, any university abroad, you can just show this digital alumni card so that you get a free entry into the university. So please do utilize the opportunity. And we are all waiting very eagerly for the topic, and I wish Vijay Ganesan all the best. Have a very successful session.
The alumni are the reflections of the institution from where they are molded as good, compassionate, and service-oriented citizens. When they venture out to the world of sheer competition, they stand apart from others. Today, we have with us Dr. Vijhay Ganesan, alumnus of 2006 MBBS batch and 2019 MCH batch. He is a gentle and compassionate human being. Currently, he is working as consultant in surgical gastroenterology and liver transplantation specialist in Apollo Hospital, Trichy. He will be taking us through an interesting discussion on obesity and liver. Before we start with the session, I would like to introduce the eminent panelists who have joined our session today, even in the midst of their busy schedule. Actually, these distinguished individuals need no introduction. We are eternally grateful for the incredible teachers we were fortunate to receive. Today, we have with us a few of those teachers as panelists. Dr. Sudhir Ovi, Head of the Department, Gastrosurgery, an amazing teacher, a compassionate doctor with surgical skills that are gifted. Any time of the day we meet him, he always greets us with a smile. His vast experience in the field of research makes him one of the pioneers of innovative techniques. Thank you for joining us today, sir. Dr. S. Sudhindran, Clinical Professor and Chief Transplant Surgeon, Department of Surgical Gastroenterology, a down-to-earth, humble, energetic person who is sought after for liver transplant not only in the state but in the entire country. He is a Zen master who works under extreme pressure with a calm that is contagious. Thank you for joining us today, sir. Next, we have with us Dr. Shaim Sadashivan, Head of the Department, Gastromedicine. Just like his name, he is a shining star in the field of gastromedicine. He has multiple publications and is always up to date with the latest developments. He is your go-to person with any personal or professional queries. You are guaranteed to get an answer. Thank you, sir, for taking time to join us today. Now, I would like to introduce Dr. Pradeep Jacob, Head of the Department, General Surgery, whom we fondly call as PJ sir. He is always very cheerful and energetic and surrounded with a group of children and students. He is an amazing teacher and a wonderful human being, always approachable and available to clarify doubts, however silly they may be. Thank you for joining the session today, sir. I don't want to take up much time as all are eagerly waiting for the session to start. Over to you, Dr. Vijhay.
Very pleasant evening to everybody here, and especially my mentors, my professors, and my colleagues, and my loving juniors. Thank you so much for joining. So, I mean, you have to thank a lot of people, but I have to thank Dr. PG Nair, ma'am, at the beginning only. So that's why I just wanted to say a couple of words about her. Ma'am has been, I still distinctively remember, I did my MBBS over here, I mean, in AMRITA. So I just wanted to sow some seeds of nostalgia. So it was in 2006 when I started MBBS over there. I remember second year, I think PG Nair ma'am still, I still distinctly remember she was taking classes for us and how she made us remember things in pharmacology, especially one incident was that beta blockers. She was taking a topic on ANS, and then she was telling that even before presentations, one might have to take some beta blockers. With that note, ma'am, I do like to confess, today I have not taken any beta blockers. Thank you so much for the opportunity given. So I think we'll go ahead with the topic. So I think if you can see this picture, I think that will give a brief outlay as to what we're going to discuss today. So the topic is obesity and the liver. I think it should have been one of the other headings actually. So it should be either baffled or by NAFLD or MAFLD for that sake. So this conundrum in the terminology arises from the fact that we have still not reached a consensus as to how to name this particular disease. So the well-established nomenclature remains that it is NAFL, that is non-alcoholic fatty liver disease. But there have been several attempts to rename it. And the alternative names which have been proposed include metabolic dysfunction associated fatty liver disease. And the other one, which is proposed by the INSL, includes dual etiology fatty liver disease. So as of now, we have not reached a consensus, but there have been meetings. And in fact, around last year in July in Chicago, I think around 32 countries have participated, including the leading organizations in the world, ASLD, ESL, all those organizations. And they have come to certain conclusions as to how we should go about changing the name. So perhaps by next year, we'll get a better picture as to what exactly the name would be. As of now, I think it is only NAFLD and like that. So let's just go into the epidemiology of the disease. So this is Western data. So the prevalence is around 30 to 25% in the general population, that is NAFL. But NASH is even lesser, around 14%, they say. But so what makes it so important in that case? Because around right now, I think it is it is the leading cause of, as an indication, NAFLD related cirrhosis is a leading cause for transplant in women, and those, regardless of the gender, who are more than 65 years of age. And it is in fact on par with alcohol as an overall leading indication for transplant. So this is the current status, but it's going to go worse from here, actually. So this is data from the Indian subcontinent. This is an article published 1 year back, I think, in the Journal of Clinical and Experimental Hepatology. So they have done a meta-analysis and a systematic review on the incidence of NAFLD in India from AIMS and SGBJI. So what they have come to understand is that around, I think, the incidence in the adults is around 38% on an average. So, and in children, it's around 35%. Startling, actually, because I think if you go through the global data, we are much ahead in that sense. So the average risk is around 28%, but in a person who's having an average risk, the incidence of NAFLD is around 28%. And in a patient who's having high risk, that is somebody who's having obesity, diabetes, and all of the other components of the metabolic syndrome, would be around, the incidence of NAFLD would be around 52%. Likewise, in children and non-obese children, it will be around 28%, the incidence. And in obese children, it goes up all the way to 63%. So, and in individuals, particularly with since we have a epidemic of diabetes in our subcontinent, the incidence in diabetes would actually go up to 56%. So this is the Indian data, actually. So what we are seeing is in line with the global obesity pandemic, rather, because I think by 2030, if you see, 1/3 of the world's overweight population would be belonging to our country, actually. So we have to do something about it, and we have to work against it. So this is just the iceberg phenomenon. What we are seeing is only the tip of it. And so the earlier we realize and we go ahead, I think we will be able to do much better things. So I'll base my talk most of it is based on the guidelines released by the ASLD, that is the American Association of Study of Liver Disease. This is published this year, 1 month back. So this is not a guidelines, but this is a guidance. So meaning there is no graded statements with the level of evidence. So going to the definition, so liver per se is not an organ in which fat is stored. So in the definition, if there's a display of macrovascular steatosis more than 5% in the hepatocytes, I think that would mount to NAFLD. So in this scenario, actually, there are certain other co-requisites. That is, there should not be any other alternative causes of this. That is, in the absence of alcohol consumption, which is, not more than 20 or, for that matter, 30 grams per day in men and women. And in the absence of other causes like medications, drugs, starvation, and monogenic disorders, that is, disorders of lipid metabolism. So only in such patients we can define NAFLD, actually. So this is just a picture showing a normal liver on the left and a steatotic liver on the right. So just to briefly give an idea, just to recollect your histology and liver anatomy, histology, it is the liver is basically divided into lobules, as you can see this dotted yellow lines over here. And in the lobules, we have a central vein, and then you have a peripheral portal triad, the hexagonal structure. This entire thing is called as a lobule. And we have zones here, zone 1, 2, and 3. So based upon how farther they are from the portal triad, these zones are based, actually. So why to go about this is because I think most of the histology and the pathophysiology would, revolve around this. So once we get this picture clear, I think we can go around. So the histological features include steatosis, inflammation, which might be lobar or even portal, and ballooning and fibrosis. So we'll just go one by one as to what they mean, actually. The ballooning or the degeneration, the liver cell degeneration, as described, as seen in this picture, is basically nothing but the hepatocytes, becoming larger in size, and the site. You can see the staining pattern as well. It becomes more rarefied in the ballooning degeneration. So the other component is steatosis. There's two types of steatosis. That is macrovesicular and microvesicular. The name suggests. I think you can see this here. This is a macrovesicular steatosis. The other one is a microvesicular. You can see the if you see the cytoplasm here, small deposits of fat. So this is microvesicular steatosis, and this is macrovesicular steatosis. So, and the pattern of steatosis is again classified because most of the NAFLD and is graded histologically by the CRN or the SAF or the NAS scoring systems actually. So what they mean is, so this triangle is a portal vein in this picture, and you can see the central vein here. So when the deposition of fat happens in the vicinity of the central vein, that is in the zone 1, it is that is one particular type of steatosis. So there is again, this is zone 1, this is zone 3, this is zone 1 related steatosis. Here it is I think pan-acinar. So there's uniform distribution of steatosis here. And then the last one is azonal. I mean, the fat distribution doesn't have any particular pattern. So as I was talking about the microvascular and microvesicular steatosis, there are different causes for why, I mean, other than the common metabolic syndrome, so, and alcohol, there are, for macrovascular steatosis, we have to think of hepatitis C, Wilson's, starvation, parenteral nutrition, A beta lipoproteinemia. And in terms of microvesicular steatosis, we have to think in terms of Rey syndrome. Most of the drugs, valproate, HR, that highly antiretroviral medicines, and other inborn errors of metabolism. So these have to be there in the back of our mind when you are considering a patient with NAFL. So this is the typical picture of a patient with non-alcoholic fatty liver. So this is macrovesicular steatosis, typically seen in zone 3. That is, this is the portal vein over here. This will be zone 1, and then this is zone 2, and then zone 3. So in this, you can see that macrovascular steatosis is happening. This is a typical picture, compounded by small, neutrophils here, so signifying the inflammation present. So based on a biopsy, ideally a biopsy would, you would require around 25 millimeters, ideally, but at least 15 or more than that is mandatory actually, with a 16 gauge biopsy needle. So if you see the first picture in this, I think one can see sort of a, it's less than 30% of the biopsy specimen showing steatosis. So this is more than, I mean, this is just to show how the difference in grading is. This is a low power microscopy picture. So this is the entire biopsy specimen is almost studded with the steatotic hepatocytes. So more than 66%, I think, would be the, involvement of steatosis here. So NASH is, so this is a spectrum. The NAFL spectrum starts with the NFLD, fatty liver, and goes up to NASH, and then subsequently cirrhosis, and then HCC. So talking about NASH, it is the next, I think, disease in the spectrum. So basically, it is compounded by inflammation and fibrosis. So you can see this, macrovascular steatosis compounded by a lot of fibrosis in this zone. So as this is a picture with the Mason's trichome, so you can appreciate the fibrosis in a better way. So when I'm talking about pediatric NAFLD, there are a couple of different things when compared to the adult scenario. So there is more significant steatosis, and ballooning is not that commonly noticed. And the steatosis is, more common in the zone 1, or it has a more pan-acinar distribution. Unlike, the adult scenario where it is rather zone 3, which is usually affected in the beginning. Subsequently, they develop all fibrosis, and so there's a grading for the fibrosis. I think just to briefly understand what that is. This is the first grade, 4 stages. I mean, there are different staging systems, but this is what is commonly followed. So one is perisinusoidal fibrosis. Second is periportal fibrosis. So connecting these two areas, when there is a fibrosis like this, you can see this here, that is bridging neck fibrosis. So this stage 3 and stage 4 are slightly advanced, and patients with NASH with stage 3 and stage 4 would be called as at-risk individuals, for whom you have to go and do, you have to pay more attention and follow up. And so that makes the important subset of the NASH population. So this is a frankly cirrhotic, nodular liver with, you can see the collagen deposition and you can see the nodule over here. This is bridging fibrosis. So cirrhosis, I think I've already explained. And the difference between NAFLD and NASH is that, NAFLD can have inflammation, but it's a requisite in terms of NASH, and also in terms of hepatocellular ballooning, that is also a requisite for NASH. So I'll not go into all the other details, I'll just cut short and then. So there's another subset of NAFLD that is called as lean NAFLD, actually. So this is a particular subset in which patients are not typically having that, metabolic syndrome, and they're not that obese. They have a normal BMI. And this normal BMI is different, as in, because for an Indian population, I think Asian rather, the normal BMI would be classified as less than 23, actually, unlike the Western population, which would normally mount to less than 25. So this only mounts to around 20% of the total NAFLD spectrum, but still it does play an important role, because you can't ask them. One of the most important treatment strategies available for NAFLD is weight reduction. So if a person is already lean and in the right spectrum of BMI, you cannot ask them to lose weight. So that's why this makes it a different sort of a subset. But by and large, they have a sort of a better outcomes in terms of cardiovascular mortality. So, and some of the studies are conflicting, but I think long-term outcomes are much better in terms of NAFLD, lean NAFLD. So, and the other aspect is, so if they are not obese, and what are the other corrective measures? I think exercise and diet would really make a difference in the outcome for such lean NAFLD. So going to the pathophysiology, I'd just like to show a video so that, to understand things in a better way. So, just very briefly to, touch upon, revise our biochemistry, So as I already mentioned, the liver doesn't usually store, fat, but it does it plays a significant role in the lipid metabolism, in the sense that it gets fatty acids from different sources. Most of them are from, lipolysis from the peripheral, tissues. Other ones are whatever we consume, which comes to the liver in terms of, in the way of chylomicrons. So in the liver, fatty acids are getting stored as triacylglycerol, and then it gets excreted as VLDL. So VLDL again goes to the adipose tissue and muscle, and it can be utilized. So basically, fatty liver is, I think, in very simple terms, a mismatch between importation and exportation, actually. So I'll just, move ahead. So again, fatty liver can be related to alcohol intake and can be related to non-alcohol intake. So that's why this NAFLD terminology has come. So I think all this has been discussed. So this synthesis of triacylglycerol, it is increased. So basically, you have fatty liver when there's increased TAG, or when there is a reduced utilization of fats, or there is decreased removal of fats. So this increased synthesis of TAG basically is because of increased fat diet, fat in the diet, and then compounded by if patient has some diabetes or starvation. So all this, starvation will lead to lipolysis, increased free fatty acids. So going back to the liver, which goes to the liver, and again, TAG is increased. So reduced utilization is typically seen in chronic alcoholism. So what happens there is that alcohol gets metabolized into NADH, and it gets metabolized into acetaldehyde and acetic acid. In that conversion, NADH is increased, actually. So, and when NADH is increased, what happens is that, the malate to oxaloacetate shunt doesn't happen. So there is not much of, oxaloacetate. So how would that make a difference? Because, so in the TCA cycle, if you could remember, so this is one of the, intermediates. So when oxaloacetate joins with acetyl-CoA, the TCA goes on. So if this oxaloacetate is not available, then it doesn't combine with acetyl-CoA. So if acetyl-CoA is stagnant, then beta oxidation of fatty acids does not happen. Hence, fatty acids get accumulated and then thereby get stored in the liver. So this is how alcohol also contributes to the fatty liver. So another one is if there's any problem in the excretion of the fat, that is removal of fat. So VLDL, as I mentioned already, is also helped by ApoB and phospholipids. So ApoB is a protein, so obviously protein energy malnutrition and other poisons like carbon tetrachloride, arsenic, lead, and also drugs like amiodarone or tetracycline. All those things will inhibit this ApoB, thereby causing decreased VLDL. And this decreased VLDL, will lead to more storage of fat. So other than that, there's also choline and inositol and essential fatty acids, which contribute to the formation of phospholipids, which is again a part of the VLDL. So if VLDL is not formed and doesn't go off, it gets stored, basically. Just to go across all the, again, choline and inositol I've already mentioned. So I have not talked about methionine. Methionine again helps in the formation of phospholipids, that is, lecithin. So that's again acetylnyl methionine is important. Vitamin E has a predominant, antioxidant effect, along with vitamin B12 and folic acid, which helps in the formation of methionine and homocysteine. So all this is essential for exportation of fat and essential fatty acids, which you have to take from the diet, which are not present in the body. Okay. So with that background, I think we'll just get back to understanding our. So what are the pathological contributors, or so obesity, as we all know, is an important aspect in which the distribution of fat is very essential, because you have an android and you have a gynoid sort of a distribution, and I think I'll not go on. It's obvious what that is. So the android distribution confers a higher risk of insulin resistance. So hence, all the metabolic syndrome, hepatic fibrosis, and irrespective of the BMI. So along with that, there is a component of adipose tissue dysfunction. So this results in, insulin signaling being progressively impaired, compounded by inappropriate release of fatty acids. So all these things happen in obesity, along with the insulin resistance. So insulin resistance is, I think, one of the hallmarks of, an NAFLD, if you see. So basically what happens is that when there is insulin resistance, there is, they are not, even in patients with NAFLD who are, not overweight, but they have a normal glucose tolerance, insulin resistance is noticed. Because of this, we understand that insulin resistance is an independent risk factor, regardless of whether there's diabetes or any of the other things, actually. So not all patients with NASH exhibit insulin resistance. So there is a sort of a heterogeneous thing going on here. So we are not able to completely understand that, but there are different parameters like inflammatory issues like SN single nucleotide polymorphisms of the peroxisome proliferator activated receptors. So this comes in the treatment as well. So we'll go in detail in that time. So IL-6 is a pro-inflammatory cytokine released, and this causes more insulin resistance. And adiponutrin is another hormone which also increases the insulin resistance. So along with that, this insulin resistance causes, enhanced peripheral lipolysis, thereby shunting more of FFAs to the liver. And then there is increased triglyceride synthesis, actually. So along with that, there is, again, more intake of fatty acids in the liver, thereby, increasing the TAG accumulation in the liver. And it is also noted that because of this, by improving the insulin resistance, we are able to treat NAFLD, actually. So the therapy, begins with this. If you understand this aspect of the pathophysiology, that is, rosiglitazone and obticolic acid, and we'll come to that in the treatment aspect. So this is the obticolic acid. Just to mention one particular thing is, basically it acts via the FSR, that is the farnesenoid receptor. So these are a group of receptors which help in the nuclear, transcription actually. So I'll just describe that later on. So not only insulin resistance, for the progression of fatty liver, the liver has to have, there should be injury. So how does that happen? Basically, free fatty acids are inducers of several, cytochrome microsomal lipooxygenases. So those cause more, free radical production. And when there is free radical production, I think the injury is getting accentuated there. So there is a shift to beta oxidation. So one thing is common, that is there is definite mitochondrial damage in the hepatocytes. So how that happens is the conundrum which is happening right now. So either with the pre-existing mitochondrial damage, if there is beta oxidation, that causes more, free radical production and then further damage. Or is it like that, or whether the free radical production and the damage is causing mitochondrial damage? And this is not still, it's like a chicken and egg. We don't know which is coming, but yeah, both are happening. That's for sure. So other than that, we have multiple hormones which are proposed. That is leptin, adiponectin, resistin, incretin. Incretin is like all GLP-1. I'll not go into the details of all that. I think other than that, there are other, aspects. That is, even patients with OSA, it is an independent, regardless of the metabolic syndrome, OSA is proved to be an independent risk factor for NFLD. So with that, and then FG21, fibroblast growth factor 21, and this thyroid hormone receptor beta. So it is an important, receptor through which we have a way of, controlling the NAFLD. Again, we'll come to that in the treatment aspect. So we must consider, uncommon causes of NAFLD, especially when you're seeing a patient with a lean NAFLD. So it is not always that metabolic syndrome is the only cause of, NAFLD. So the other causes which you'd like to think of is, disorders of lipid metabolism, as I've already mentioned before, A-beta lipoproteinemia and all the other things, glycogen storage disorders, Weber-Christian syndrome, lipodystrophy, and patients who are receiving, long-term TPN. So that is again another, risk factor. So I'll come to that shortly. So hepatitis C co-infection and medications, as I mentioned, amiodarone, tamoxifen, methotrexate, corticosteroids, and antiretroviral drugs, starvation, Wilson's disease, actually. So we must keep in mind, when we see a patient with the, histological picture of fatty liver, we should not miss any of these things, especially, in a very unlikely case. So I think this I've already mentioned and I've described. So this is just to reiterate the fact, this is a patient who has had short bowel syndrome and is on chronic TPN. And one can notice the hepatic, steatosis over here. And along with the steatosis, you can notice the, lobar inflammation. And this is an insipated, bile duct with a small ductular reaction over here. So quite similar to what a NAFLD patient or a NASH patient would be, isn't it? So this is a patient with, who has been having arrhythmias and who has been treated with amiodarone, chronic, treatment with amiodarone, and then this is what it has caused. See, you can see the ballooning here. As I mentioned in the first slide, you can see the ballooning, and this is the Mallory-Dank bodies, and these are lobar, inflammations. You can see this neutrophils over here. This is again amiodarone toxicity, quite similar to, what NAFLD would be. So this is a child with, Wilson's disease. So you can see even in Wilson's disease, so what happens is, the thing which I forgot to mention is, so all of these diseases, there is basically deposition of fat by one mean or other. So in TPN, for example, what happens is there is a deficiency of carnitine. So this carnitine is very essential for the shift of fatty acids from the cytoplasm to the mitochondria. When that doesn't happen, so beta oxidation is getting stopped, and when beta oxidation doesn't happen, fatty acid accumulation happens and fatty deposition happens. Like that, even in amiodarone, as I mentioned already, it inhibits apoprotein and then that's why fat is getting accumulated. Similarly, even in Wilson's disease, what we can see here, steatosis is obvious. Along with that, you can see this periportal fibrosis with inflammation. So how in Wilson's it happens is that, copper is getting, there's a ATP7B, gene mutation in which copper is getting accumulated. And because of this copper accumulation, beta oxidation is again getting inhibited. So that's why, fat is getting more deposited in the liver. So that's why you can notice the steatosis again. So we should always keep all these diseases in the back of our mind when you're treating a patient with, NAFL. So this is another patient, again with methotrexate, similar picture, steatosis, fibrosis, all those things similar to NASH. So along with that, so I think other two drugs which I wanted to talk are tamoxifen and corticosteroids. Both of them again cause, again accumulation of fat and then NAFL. So one thing with both corticosteroids and tamoxifen is that this effect of producing a fatty liver is exaggerated, especially if there's a compounding metabolic syndrome. They already have fatty liver and all those things, and this will aggravate that. So just to summarize the pathology in one slide, there are two hits. So the first hit is very obvious. As I told already, insulin resistance. That is almost, universal. When insulin resistance happens and, fat is getting deposited due to various means, as I already mentioned, compounded by that, there are multiple, one thing which I have not talked about is, gut dysbiosis. That's coming up in a very big way right now, that the spectrum of our gut bacteria. So once that changes, it causes more endotoxin production. It causes more mitochondrial dysfunction in the liver. So this is coming up in a big way now as one of the etiologies for progressing the NAFL from the NAFL to the NASH stage, by maintaining the constant state of inflammation. So NAFL, NASH, and then cirrhosis, and after that, this can progress again to HCC. So I think I'll skip all this. And natural history. So we saw the spectrum. So what we have to do is basically find out at-risk candidates for whom we have to do some sort of intervention or more frequent screening. So the at-risk NASH is what I've already described, that is anything beyond stage 2 fibrosis. So what they have found is that when somebody has, NAFL, when compared to NASH, one can see that, there are 4 stages of fibrosis. So it takes around 7 years in a patient with the NASH for upstaging a fibrotic stage. That is from stage 2 to stage 3, for example. It will take 7 years in NASH. And for NAFL, it might go from 14 years, from stage 2 to stage 3. So that change in the fibrosis is, depending upon the extent of inflammation present. So why that is important is because once you diagnose cirrhosis, we have to do biennial, screening for HCC, screening for varices, and, monitoring for decompensations, because the rate of decompensation is around 20% per year. So hence the important aspects. So this fibrosis and this progression is all dependent upon multiple things. It's heterogeneous, that is multiple comorbidities, genomic profiles, and also environmental. A lot of epigenetics is involved here. So what they found out in the meta-analysis is that patients who are getting treated for NASH in 35 trials, even with non-pharmacological factors like frequent visiting the doctors, making dietary and lifestyle modifications, can reduce the progression of fibrosis. So this is proved in a meta-analysis. So the most important thing is, what is the most common cause of death in NAFL? Rather, it is not liver disease, but it is because of cardiovascular, actually. So as a part of the spectrum of metabolic syndrome, I think the most common cause of death in NAFL is actually cardiovascular. So hence, we have to make sure we take adequate measures to prevent deaths because of this. And the second most common cause is actually extrahepatic malignancy. That is, and then last being liver disease per se. But I think the numbers are so large that even liver disease per se, because of this, will contribute a lot. So evaluation, I think if you go by the ASL guidance, so I think history, physical examination. History is rather asymptomatic. Patients, most of them are asymptomatic, incidentally detected. Very, very seldom do you get a patient with, who's having a right hypochondrial pain or some vague discomfort or something like that. But by and large, it's asymptomatic. During screening is when you pick up these patients. But in the history, what is essential is that you have to, evaluate for the presence of comorbidities like diabetes, presence of any cirrhosis in the family. Because a history of cirrhosis in the family, there's a 12-fold increase in the odds of this patient developing cirrhosis. So that's very essential. And alcohol consumption, duration of alcohol consumption and the quantity, etc. Along with that, what are the other comorbidities? So physical examination, I think you have to look for features of CLD, which is obvious. And then other than that, the distribution of fat and, so along with that, what is essential is to, have a basic panel of, liver function tests, CBC with platelets, fasting glycated hemoglobin, fasting lipid profile, urine microalbumin, and, hepatitis C, because as I mentioned earlier, that is very similar. The histological picture is very similar to what NAFLD would be. So, and to make sure that we don't miss all that. And in very confusing cases, to go for other, evaluations if there's a persistent elevated transaminitis, that is, look for any autoimmune disease, for any, ceruloplasmin and all other parameters. So the chance of, if you're screening a person with the following comorbidities, what are the odds of one finding advanced fibrosis? In a patient with diabetes, it would mount around 6 to 20%. Medically complicated obesity, that is a obesity patient with some sort of, complication, would around, it's a variable thing, 4% to 33%, the chance of advanced fibrosis, that is stage 3 and above fibrosis. So NAFLD, in the context of moderate alcohol use, you'll find around 17% chance of fibrosis. First degree relative, again 12%, 12 times, and around 18% chance of finding fibrosis. So this is a small, a diagram which, is taken from the ASLD guidance to just give a brief. It's a bit congested. I apologize for that, but just to explain what it is. So there is a primary risk assessment, and then there's a secondary risk assessment. So this is done via, a test called as, FIB4. FIB4 is nothing but, a combination of age, AST, platelet with a formula. And based on that, you get a score, which can be based on different measures. It can be 1.4, or like, for this, all practical purposes, they have taken it into 1.3, 1.3 to 2.6, and more than 2.6. So any patient with the FIB score who's more than 1.3, that is, if you see it is yes, then you have to, see what, if it's more than 2.6, directly, I think, send for advanced care. So primary care, this is primary care physicians should send the patient for referral. That is, when the FIB4 is more than 2.6, straight away. Or if it is less than that with persistent transaminitis, I think, again, that's another indication for referring to a specialist center. So along with that, I think, if there is if it is less than 1.3, the FIB score 1.3, then again, based on whether the patient has multiple comorbidities like diabetes or, metabolic syndrome, we'll increase the frequency of monitoring. That is, if diabetes is present, 1 to 2 years, you'll monitor the FIB4. If it is not present, then at least the gap of 2 to 3 years is fine, provided they have less than 2 metabolic factors. So once you do the assessment, the secondary assessment is done by this. This is coming up in a big way, though we don't normally use it in our unit, but I think things are changing. So VCT, that is, vibration controlled transient elastography. So this is a tool for secondary risk assessment. It can be done in the primary setting, or it can be also done in the secondary setting. That is basically liver stiffness, LSM, liver stiffness measurement. So again, that is again giving objective data of less than 8 or 8 to 12 or more than 12. If you see if it's more than 12 or 8, I think it's better to refer to a specialist so that they can follow the patients. If it's less than 8, I think it's the low risk and then can be handled in the primary care center. So the other one is ELF, that is enhanced liver fibrosis. I'll just come to that in a bit. So if the patient is found to have any of these, that the FIB is more than that, so I think we will go to the second level of reassessment, secondary reassessment done at a tertiary care center. So that is, again, we segregate them into low risk and then intermediate or high risk. If there's intermediate risk and there's discrepancy between the parameters, we should consider liver biopsy. If it is straightforward and there's high risk, I think, based on that, that is ELF is more than 11. I think it's straightforward cirrhosis. You can diagnose that in imaging only. So biopsy, again, as I already mentioned, stages are there. Stage 4 is cirrhosis, stage 2 to 3. If you're finding out that, I think one should consider primary and secondary prevention aspects for cirrhosis. So FIB4 I've already explained, and the issue with FIB4 is that it varies with age. That is, less than 35 and more than 65, it is very, variable. So this is usually suitable for the age between 35 and 65. So this other parameter, what I was talking about, is enhanced liver fibrosis score. This has come up in a big way, but I'm not sure how commonly it is used here in India. It's hyaluronic. It's basically a serum marker with 3 parameters. That is hyaluronic acid, procollagen, and TMP. It's a serum marker. Based on this, you get a number, the score. If it's less than 7.7 or 7.7 to 9.8 or more than 9.8 or 11.3. If it's more than 11.3, it is a definite cirrhosis. Less than 7.7, I think stage is less than, less than any advanced fibrosis. So there's another, I think I'll not go into this because we have already described this. So this is another description based on the INSL guidelines, which Dr. Ajay Duseja and colleagues have published from PGI, I think last year. They have an Indianized version of how to assess a patient with fatty liver. And, the only difference, I'll not go into the details of it, but just to mention that there is one scoring system, that is AST with, there is the APRI score, which is slightly different, but they are using that as well. That is the only difference in that and this. And subsequently, in cases, again, they're using LSM to, categorize as to whether it is severe or more. So coming all to that, should we really screen a patient, general population? I think as of now, no. The guidance is very clear that we need not screen a general population for NAFLD, but in high-risk individuals, definitely, I think one should consider screening by different means, and as I already mentioned, primary risk assessment, secondary risk assessment. But I think by and large, what commonly happens is that most of the patients get an ultrasound invariably for some pathology or some symptom, and they end up, we end up detecting fatty liver. I think that's how most of us tend to see patients in the clinic. So in this, the problem with ultrasound is the sensitivity of ultrasound is very bad. In the sense, if there is a low degree of steatosis, the ultrasound might even miss that. So that is the issue with the ultrasound. Otherwise, I think, so what is the solution for that? I think is we have to use VCT, that is liver fibroscan is what is being promoted, but control attenuation parameter. This is a way of assessing the degree of steatosis. So this provides a score. CAP provides a degree of score, and based on the score, the degree of steatosis is established. So that is not good, especially in more than severe steatosis. It is not good in identifying patients with severe steatosis, CAP. So ultrasound, so what we commonly see is, mild, moderate, severe fatty liver. So what is that mild, moderate, and severe fatty liver? These are 3 pictures. If you can go through this, this is the first picture, normal, almost near normal liver. You can see the, intravascular, anatomy, which is clearly established. You can see that. You can see the, diaphragm over here, the diaphragm shadow. But progressively, you can see this is slightly, more steatotic liver. One cannot see the diaphragm here. And also that the clear intravascular markings which were seen previously has not been seen here. And the last is severe fatty liver. You can't make out anything. It's completely like this. So, and along with that, we in our unit used to use, CT, plain CT for, especially for donor evaluation. I'm not going to talk about that, but just for completion's sake, I'm just talking. So along with that, there are other multiple non-invasive parameters which have come. I think I've already mentioned a few of them, fibroscan, and this MRI PDF is PDFF is proton density fat fraction assessment, based on which you get a number to understand how bad the steatosis is. So, and to identify at-risk individuals, you have all this FAST, MAST, and MFib. FAST is nothing but, using FibroScan in combination with the AST. And MAST is similarly using MRI with combination of AST. And it provides, cutoff points for whether, is it bad or how bad it is. Along with that, you also have this ME Fib, that is basically Fib4 compounded by MRI elastography. And last is CT1. CT1 is basically corrected T1 MRI scan, which helps to identify the at-risk individuals. So I'll not go into all the details, but I think basic idea is very clear. I think ELF is what I've already talked about, enhanced liver fibrosis index. So along with that, you have VCT. So these are cutoff points for ruling off. So if Fib4, this is the rule in. So if rule in meaning, if Fib4 is more than 3.4, then that is obvious. Actually, patient is said to have cirrhosis. If it's less than 1.6 or 1.3 for that matter, you're ruling out. Like that for various modalities, these are the cutoffs. I'll not go into the details of it. CAP score, just to show that state S1, S2, and S3, basically it means the degree of, steatosis. So after that, I think I'll just go, because it's getting late, I'll just go directly into management. Management is, I think, it's a multidisciplinary management. It is not pertaining to one particular department. I think we need inputs from multiple departments. So why? Because diet is, I think, the basis of management is very simple. So weight reduction, exercise. So they form the most important pillars. And so weight reduction in which quantity? That is, if you're losing weight at a rate of more than 5%, we can reverse NAFL. But you need a weight loss of more than 10% of the body weight to show changes histologically, or to show changes from NASH to NAFL at least. For NASH, you need more than 10%. For NAFL, at least 5% of body weight, in simple terms. And for fibrosis, even more weight loss is expected. Okay, so basically we stratify patients at the primary care, and along with that we take input from other departments like cardiology, and for the management of the most common cause of death, as I already mentioned. So hence cardiology is involved, and along with that our tertiary care hepatologist and all that, compounded by nutrition and also counseling. So the diet, what they're recommending is the Mediterranean diet, which is, I think, predominantly seen in the area in Spain, France, Greece. So I think I'll not go into the detail of it, but just to give a brief, what sort of, in the French Riviera, what people eat normally. So is what is being advocated. Along with that, exercise, I think, so you have to become more and more objective. So this is the CDC recommendation. They say that at least 150 minutes of brisk walking. So what they recommend is moderate intensity aerobic activity. So that would mount to around 150 minutes every week. That is 30 minutes a day, 5 days a week, compounded by muscle strengthening activities involving most of the major muscles. Okay. So this is the objective. Rather than telling your patients go do an exercise, I think we should be more objective, so thereby they can follow this. So, and what is the role of bariatric surgery? It's coming up in a big way, in the sense that bariatric surgery, the current indications are very clear, that is more than 35 BMI with comorbidities, or 40 BMI without comorbidities. So what are the comorbidities? Diabetes, hypertension, and obesity related things. So NAFLD is creeping into this particular comorbidity spectrum of for whom even at a BMI of more than 35, one, I think, can be recommended for bariatric surgery. So at 1 year, the survival rates, the improvement, there's a 80% improvement in the steatosis rates, actually. So, and NASH resolves in such patients, and we are able to sustain weight loss up to 30%, cure diabetes also. So, it decreases morbidity and mortality, but per se, it is only in the spectrum of NAFLD. not in terms of patients with compensated liver disease, or even for definitely not in the case of decompensated liver disease. So that can be only done in high volume centers with much experience, bariatric surgery and transplant. So coming to the medications, I think there are a few drugs as of now. I'll just go very briefly into it. My time is running out. I don't want to go into the depth of it, but just to give a picture, as of now, there is no FDA approved drug for I think NAFLD as of now. I think I can be subject to correction, but I don't think so as of now we have any drug. But the commonly used drugs are vitamin E, pioglitazone, and liraglutide, and the other drugs, semaglutide. These are upcoming drugs, semaglutide and tiragolumide. So how basically they're classifying is, I'll just go around a few of the landmark trials in the drugs. So this is a classic PIVENS trial, which came around 12 years back, published in NAGM. So they have, I think, divided the patients into 3 groups, that is pioglitazone, vitamin E, and pioglitazone placebo combination. So what they've done is, based on this, I think we have clearly established that there is no improvement with fibrosis with pioglitazone, with vitamin E or anything for that matter, but there is definite improvement, which is the p-value is significant in terms of steatohepatitis, that is in vitamin E. So hence started the practice of prescribing vitamin E. So this one major thing, what you have to understand in the trial is that this patients did not include this cohort did not include diabetic patients. So the use of vitamin E in a diabetic population is still, I think, it's debatable. So and rather we should not. So there are multiple other drugs. This is a new drug which is coming up, which is called as a FASN inhibitor. Basically this is to decrease the fatty acid production. The trial is fascinating. I think I'll not go into the depth of it, but this is another drug. Apologies for the picture. The slides have been taken from somewhere else, so I couldn't properly put it. This is saroglitazar. This is a dual PPAR receptor antagonist. So this is based on the evidence 4 trial which is conducted recently. So there is basically they have combined saroglitazar 4 mg, 2 mg, 1 mg, and they have seen changes in ALT, changes in fat, reduction in liver fat. So 4 mg, I think clinically significant reduction in fat, and also clinically significant reduction in ALT. So this saroglitazar is basically as I was mentioning, this paroxysmal PPAR gamma and alpha, a dual agonist. So it improves the insulin sensitivity, thereby improving the plasma lipid level. So that is one. And then this is a new trial again published recently last year. I think it's a regenerate trial. So what this has done is basically they have tried OCA, that is obticholic acid, and they have seen at different doses, that is obticholic acid at 10 mg and obticholic acid at 25 mg. So as I mentioned earlier on, I think obticholic acid through various means, but also through the FSR, that is the fascinoid receptor R. So it decreases, the amount of decrease, what you can see is 23% in terms of, improvement in fibrosis with the 25 mg group, and 10 mg in terms of 10 mg. So, there is a dose related, improvement there, but NASH resolution without any worsening of fibrosis, again, there is, improvement, but it is not clinically significant. So you can see the protocol and the intention to treat analysis there. So obticholic acid is currently, I think, the only drug which can, slightly improve the fibrosis state, even though it's not approved. So the future, treatment is based on multiple drugs. There are a lot of drugs in the pipeline, and the next 6 months, I think we'll get most of them. So GLP agonist, that is incretin, I was telling, anti-diabetics, SGLT2 inhibitors, that is dapagliflozin, and this new thyroid receptor beta inhibitors, resmetirom, and the fibroblast growth factor 21 targeting drugs, aminoresin, and other pan PPR drugs, lanifibranor. So I'll not go into all the depth of it, I think, because there are multiple trials for each of them. So I think I'll just like to leave it here, and before saying that, I think I would like to, mention a bit of drugs. So there are a lot of other drugs in the market which have no evidence of any, histological changes or benefits. So the one of them is UDCA, so metformin, and this, statins, and of course, Silimarin. So there are multiple such drugs available, but I think we should, I don't know, we should not think of it at all, because there is no evidence, because we don't see any change in the histology based on treating with them. So and I'd like to thank my entire team for I think making me as to whatever I am today. So all the members of my team, I think, are very thankful to them. So I am whatever I am today only because of Amrita, nothing short of that, actually. So special thanks to Dr. PJ, actually. So I must mention sir, because basically, if it wasn't for sir, I think I wouldn't have never chosen surgery. So I still remember what, Ramya was saying, such an enthusiastic person, and he usually has a bunch of students, children going around with them. So I was one of them. I was one of that children who was going around with them. And sir is, I think, one of the most excellent surgeons I've ever seen. And he made me develop a love for surgery. So I mean, I really thank him. And so the other person because of whom I took surgery was Dr. Sudhi. So I still remember sir's rounds with Dr. Sudhi when I was a third year MBBS student. So I was quite interested in general medicine, actually, but sir sir has this charismatic capacity to pull people over to another branch. So I was very inspired, and I thought, okay, surgeons can be great physicians as well. So hence, I learned a lot from sir. This is a photo of me meeting sir after MBBS, but before MCH. I had met him in Brazil. I was asking him, like, I wanted to join somewhere where there's good HPB work being done. So sir was just casually telling, no, why not Amrita? So that time NEET wasn't there. NEET SS was not there. But then whatever he said, I took it very seriously, and NEET SS came, and then luckily, God's grace, I joined Amrita. I think probably a career-changing move for me. So this is a very famous poster for most of us who used to, know Sir's, who has seen Sir's old room. So he has this excellent saying, I'll never forget this. So I've taken a photo of it for always remember. Do it now. Today will be yesterday, tomorrow. I think he has it. I think Sir has changed his room, but it used to be there in his previous room. A very inspiring quote, and Sir is, really, is a very inspiring personality, and excellent. Sir has taught me about team. And I think if for all the youngsters, I think you should read this article by Sir for how to build team building in difficult situations, tips and trick. So I can share this with whoever is interested later on. It's a huge, it's like, I think, a life-changing moment for me when I read all that and all. So thank you, sir. Thank you so much for that. And Dr. Sudhir, I mean, I'm immensely grateful to sir, because sir, I mean, I was more interested in transplant when I joined AMRITA, but sir is such an excellent surgeon. And I mean, I got so attracted to the other aspects of GI, and, I was so fascinated. I'm still inspired by sir. And he has taken excellent care of me. I mean, I had very difficult times during my MCH, and I'm ever grateful to sir, the way in which he has taken care of me during those periods. And he has taught me something very important. I'll never forget that. I'm not sure whether you'll understand, but he taught me something called as Nirguna Parabrahman. It's slightly deviating from the topic, but those who want or interested can read about it. It's a Advaita philosophy. Sir is a philosopher. He has completed a course in philosophy. That side of sir, I think not many of us would know. But thank you, sir. Thank you so much. This is a picture of sir. He was a mentor for a colorectal workshop, I think, conducted recently in, if I'm not mistaken, in MS Ramaya. So, I mean, I would like to thank the entire team, Dr. Dinesh, Dr. Puneet, and everybody else for making whatever I am, and all the faculty of Amrita. I chose this topic because I think 19th of April is a World Liver Day. So I think to give context to the World Liver Day, I think this is a topic, hence I chose liver, and not to mention the gravity of what we are facing. So yeah, thank you so much for your patient listening, and
Thank you so much, Sheta, for beautifully explaining the etiopathogenesis and management of liver disease, especially in the obese population, in a simple way. And now we are open for discussion. If there are any queries, you can ask. Uh, we have a few questions for the moderators. This question is to Dr. Sudhir. Sir, what is your experience with obesity and lifestyle diseases in the present times?
Yeah, that's a very pertinent question. Yeah, actually, initially, our principals were saying that we were wondering what would be our career. What actually he meant was all of us, all our doctors were worried that if people become healthy, yeah, if there's no disease, what we will have the new doctors to treat. But we are facing new challenges like this, the lifestyle diseases, more obesity, the obesity-related problem, which were not there before. So there are enough opportunity for the young doctors to make their career. Like here also the obesity related, the lifestyle disease problem is mainly the obesity issue. That's what is meant by that. Yeah, one of them is the, as today we discussed, the fatty liver disease, which is associated with obesity. The obesity associated fatty liver, we have conducted a study which has shown that around 90% of the patients, 90% of the patients who had undergone obesity surgery had NAFLD. Yeah, and I would say that around some 60% of them were having NASH. So all these patients are having a high propensity or high, threat of having hepatocellular carcinoma or chronic liver diseases. And once you do the obesity surgery, this has completely reversed also. We have done a paired biopsy after 6 months, and we have seen that the NASH has completely, or the fatty liver has completely resolved in them. The lifestyle diseases like the diabetes mellitus, the sleep apnea, the other cardiac comorbidities, and hypertension, dyslipidemia, everything are relieved by doing an obesity surgery. So why obesity surgery is, that's only the sustained, cure or sustained weight loss will be provided by the surgery. Even a good diet, lifestyle management, and if you can reduce your weight by around 10%, all these comorbidities might be resolved, but it may not be sustainable weight loss. That's the only point why we do this obesity surgery. But if there are some other ways to reduce your weight, of course, a surgery can be avoided.
Thank you, sir. Thank you so much. And next we have a question for Dr. Sudhindran, sir. Sir, what is the post-operative outcome in a liver transplant case of an obese patient compared to other individuals?
Thank you. It's a good question. And Vijay, it's a fabulous talk. Enjoyed every bit of it, particularly the good things you told about us. Thank you. The question. So I think morbidly obese patients in any field will have a higher morbidity and mortality compared to somebody who's not non-obese. So whether it is standard surgeries, whether it is occurrence of malignancies, whether it is lifespan. So even liver transplantation, actually technically it may not be that much more difficult, but the biggest problem will be that following successful transplantation, the occurrence of recurrent NASH and recurrent fibrosis secondary to the NASH is very high even following transplantation. So I think that is the biggest problem. And currently we are trying to see how we can approach that situation, because invariably all those patients, when they develop cirrhosis, they lose their weight, the liver becomes fibrous and they lose all their fat, the dyslipidemia comes down, all that will happen. The moment you do the liver transplantation and it becomes successful, everything returns back to its original position. So they put on weight. How much ever we counsel them, the exercise doesn't happen, the diet is not adhered to, and within about a year to 2 years, I think almost 60 to 70% of them will put back their weight. So that is the biggest problem. So currently, I think we are doing a trial on two things. One is obeticholic acid in these patients, and the second one is the saroglitazar in these patients. post-liver transplant patients preventing NASH. So 2 randomized trials are going on now. Thank you.
Thank you, sir. Thank you so much. Next, we have a question to Dr. Shine. Sir, is liver disease more common in obese females or obese males?
Yeah, I think it is more in obese males.
Okay. Also, the next question is how often should they screen for liver diseases, especially in obese patients?
How often?
Should they screen for liver diseases? Obese patients, how often should they screen for liver diseases?
Actually, when a patient comes with a altered LFT, especially an obese person comes to you with a altered LFT, liver enzyme elevation. So SGOT, SGPT elevation. So any patient comes to you with SGOT, SGPT elevation, I think the first thing what you have to do is do the viral markers, HBsAg, anti-HCV, ceruloplasmin, ferritin especially in all males and females post-menopausal. So ferritin and autoimmune. So we have to rule out all these 5 causes. And then if the patient is obese, then we have to specifically look for metabolic syndrome associated with hypertension, diabetes, dyslipidemia. So all these things are to be checked.
Okay, sir. Thank you, sir. Also, if you can, sir, can you give some career guidance advice to our young budding doctors who might be interested in joining gastrosurgery or gastromedicine or even hepatology?
Career guidance.
Yes. Opportunities in the field, sir.
Yeah, actually, when we joined gastroenterology, so we never knew that this is expanding like anything. So now, so it has first it divided into hepatology, gastroenterology. In gastroenterology itself, now the opportunities like inflammatory bowel disease is coming up in a big way. Especially in inflammatory bowel disease, I think the literature in India is very, very less. And now because of the westernization, what happens is the number of cases of Crohn's disease, ulcerative colitis, everything is increasing. So recently we had an international conference on inflammatory bowel disease, and they were all suggesting that there is a new option. So for a gastroenterologist, they can subspecialize in inflammatory bowel disease. Another field which is actually unexplored, because a patient comes to you with a abdominal distension or irritable bowel-like syndrome, and the moment you do an upper GI endoscopy and lower GI, you say that this is functional. And then patient is labeled as irritable bowel syndrome, and then he will suffer the whole life. And nobody will be going into the depth of it. But functional bowel disease, it gives a lot of area to be further evaluated, because esophageal motility, gastric motility, small bowel motility, large bowel motility, anorectal manometry. So a lot of areas are still not fully evaluated, and then youngsters are having a lot of chances for this. So motility disorders, inflammatory bowel disease, and then NASH itself is actually a huge area. Non-alcoholic steatohepatitis, and then then surgical, this thing we already discussed, no, transplant or liver transplant. So opportunity is definitely there. And then because as Sudhir said, obesity itself will cause several complications, and then we need people to take care of such complications also.
Thank you, sir. Thank you so much. I hope few of our students will be inspired to join this field, and they might be getting a lot of guidance from all our teachers here. So please utilize all these opportunities. And I have a question for Dr. Pradeep. Sir, how do the post-operative outcomes differ from people with obesity and associated lifestyle diseases?
Hi, good evening.
Hi, sir.
Nice.
Vijay, congratulations.
Sir, thank you so much, sir. Thank you, sir.
Nice to see you.
Pleasure. Pleasure,
Nice to
sir.
see you again. I still remember you as the young 19-year-old shy boy who was. I've not changed my room. I'm still in the same old room.
The room in which we used to stand still, sir.
Exactly. I still had a bunch of kids. Today was Wednesday, my OP day. I still remember, I think 6 or 7 of you from your batch. And I think at least from that small batch, I think 3 of you went on to take surgery. Vimal is in surgery.
Yes, sir. Yes, sir. He is in surgery, sir. And I forgot to tell one more thing. I still distinctively remember you calling me when I was doing surgery residency. I don't think so anywhere in the world.
You're in Himachal. Yes,
yeah, yes. You called me that time, and I'll never forget that. I mean, not everybody. Ideally, the student is supposed to call, but I still remember. Thank you, sir. Thank you so much for all that.
Wonderful talk, Vijay. So glad to see you again.
Pleasure, sir.
Coming to your question about post-operative outcomes. Obviously, like Sudhir sir said, obesity seems to become the mother of all diseases. So definitely, it impacts surgical outcomes as well. Even though we advise our patients to cut down on weight before we offer elective surgeries. Usually nothing materializes, and we usually have to pay the price with post-operative complications, be it increased risk of surgical infections or deep vein thrombosis in spite of adequate prophylaxis. It definitely adds to the burden of surgery.
Thank you, sir. Also, can you also give some advice to our students regarding the opportunities in the field of general surgery, sir?
Like Vijay was telling, that I inspired him to take up surgery, but of recent, I think I'm losing my touch, losing my thunder. I think MGK Pilasar is slowly encroaching into the surgeon's domain. You see more and more of our students opting for medical specialties. I'm not sure why, but there are still very diverse fields of surgery that you can branch into. If you're interested, you can stay back in general surgery and do wonderful work in general surgery itself. Like many of us in general surgery at AMRITA, we have our own niche areas. You find Misha madam working mainly on breast. You see CGN sir and I focusing on thyroid. Riju branching out to veins. So even staying back in general surgery, you can choose your field of interest, work on that particular area. If you choose to go and do a specialization like Vijay did, yes, you have ample opportunities. We've had many of our So opportunities are ample, but it requires surgery is as I always say is a team game. So you should be willing to be part of a big team. Like Vijay was showing a picture of the entire GI team, how they gel and work together. That explains why our GI surgery department is very successful. You need to be a team member.
Thank you, sir. Thank you so much. Thank you all teachers for such amazing, wonderful advices and answering all our queries. So all good things must come to an end, and it is time to close this short but interesting session. Before that, I would like to thank each and everyone who took the time to join us today for this session. I would like to begin by thanking our beloved Amma, without whom this would not have been possible. My pranams to Amma. I would like to thank Dr. Prem Nair, Provost and Group Medical Director, AIMS, for supporting us in all these ventures. Next, I would like to thank Dr. Girish Kumar, sir, our beloved principal who joined us today and always encouraged to hold sessions like this. I would like to extend my gratitude to our beloved faculty members who taught us and inspired us to bring out the best from us. Thank you, everyone. I would like to thank Dr. Vijhay Ganesun, star of the session today, for giving such insightful information. Last but not the least, I would like to thank the backbone of the event, a person full of energy and always active. She is a motherly figure to all of us. It is none other than Dr. P.G. Nair Madam, Professor Emeritus, Department of Pharmacology, and Coordinator of the Nodal Center for our statutory inspections. And she is the Chief Coordinator of Campus Alumni Association. Thank you, Madam. Now, I would like to thank the IT and Audiovision team. Without this technical support, none of this would have been possible. Thank you so much. Please forgive me if I have missed out anyone. And thank you once again to everyone who joined us today. And now we'll conclude the session with National Anthem. Please rise for the National Anthem. Thank you, everyone.
We have our next session on 3rd of May by Dr. Jyoti Priya.
And I would like to take this opportunity to invite you all to join us for the session. Thank you very much. Loka Samasta Sukhino Bhavantu.